Hello, so today we are going to be talking about the cranial nerves, which can help evaluate the central nervous system. So to get started, I'd kind of like to start talking about my background as an emergency room nurse. There's your obvious, assessments of the central nervous system and the damage. If somebody has suffered severe trauma or stroke or has a really obvious cause, the cranial nerve assessment really won't work for those patients. We would probably use like the Glasgow Coma scale and things like that. However, the second part of that is using it for things such as minor head trauma. If somebody gets hit in the head, if they walk into a pole, if they have like a hematoma, all kinds of things like that. And, they could be exhibiting more subtle signs, or maybe even in your patients that just kind of have vague complaints. And we're trying to look out for some other signs or trying to detect or make a differential diagnosis of what's going on. So I'd like to start there. So the first thing, the cranial nerves travel through exact locations in the brain. And so because of those exact locations and what they affect, if we understand how they work and what they affect, we can know maybe what part of the brain could be affected. So we're going to just go through them and jump right in, and we're going to kind of talk about some normal things versus some abnormal things. Let me advance my slide. So cranial nerve 1 is in charge of our sense of smell. So obviously in the setting, you would assess, you could use like a little container of coffee or something that's not noxious or like aggressive. If they can't smell or if they're losing a sense of smell, you have to evaluate the possible causes. So that could be trauma that interferes with those nose olfactory fibers. They could have a tumor in their frontal lobe that could be compressing on that nerve, which would alter the smell. So that's kind of a thing that would alleviate, lead us to that thing. So obviously the patient comes in, you ask them to smell, don't let them see it, ask what they are smelling. And if they can't smell, then that would be an abnormal finding. This also will be done in like a sequence. So it can be, done like in one area, and I don't like clumped together. So cranial nerve 2 is in charge of visual acuity, your visual fields, and your ocular fundi. So like to sum that up, vision. So if you had vision loss or unilateral vision loss, again, major possible causes, trauma, most predominantly to the optic nerve. You could have a lesion somewhere. You could have neuritis, which I have seen in the ER, or you could have a neuropathy in your optic blood supply. So that would be a problem. To test this, we typically use the Snellen chart. Most nurses will understand. You walk in, you have them, stand the distance of the chart. Besides for reading glasses, you make sure they're wearing the corrective lenses. You cover one eye, ask them how far they can see, have them cover the other, and then you do, both eyes together. Obviously, if there's a skew from that or it's anything from their baseline, that would want to be noted. So another thing, the visual fields, if you're standing in front of them, you can, do the peripheral screening, how many fingers, and then move down, how many fingers. So that would be another concern. And then learning how to use your ophthalmoscope to illuminate the retina, and make sure that you can, I try and find the blood supply and follow it down to the circle. And I'm not skilled at this right now, but as I get more skilled, I think that would give an indication if there was, maybe you could visualize something or identify something was going on from there. Next, we're going to move on to the optic and oculomotor nerve. This again can all be kind of assessed at the same time when you're working on the eyes. So obviously you're going to be looking at the patient, you're going to be assessing all aspects of the eyes. We're going to come from the side, assess their pupillary reaction to your pen light. So are the pupils, restricted like when the light shines, they get bigger when they go away. And you also want to assess the eye movement. So if you hold a pencil or whatever tool you're using at the tip of their nose, do their eyes, focus in? And then if you out, like, are you're trying to see your peripheral, do they focus there? So let's see, if there were things to look for, would be a dilated pupil, like if one is non-reactive and dilated, loss of accommodation, if like one eye was deviated, and if they had a loss of a levitator function, that could cause it. Again, causes could be trauma, vascular, and that's all I can really think of for that. I guess ischemic, diabetic patients could have this. So all good things that could lead you to, assess a complaint of your patient. All right, so cranial nerve number 4, trochlear, is going to assess the eye movement using your finger to monitor this. So most likely this is a motor function that assesses the superior oblique muscle of the eye. Abnormalities would be the inability to move your eye downward and laterally, diplopia, or if the patients tilt their head toward the unaffected eye to overcome the rotation of the affected eye. And the most common cause of this is just trauma to the nerve of that area. For cranial nerve number 5, trigeminal, this is a motor supplied to the muscles of mastication. So chewing, things like that. And it also can be used in sensory to the face and oral cavity, to include the tongue. So abnormalities when assessing this would be if like you were trying to do sensation on their face and they had some anesthesia there, they had pain on their face that was like associated with chewing or brushing their teeth or light touch. I know that trauma, again, I sound like a broken record, but that could be a leading episode of this. Cranial nerve number 6. This is going to supply motor supply to the lateral rectus muscle. So again, at the eye, inability to move an affected eye laterally, or if you have diplopia, on attempting a lateral gaze. Again, a tumor. So it also, this is an indicator of if you have any lesions in the cavernous sinus that could compress the nerves, or if you have increased ICP, intracranial pressure, that could cause abnormality in this cranial nerve. Cranial nerve number 7, which is your facial nerve. Motor facial movements, obviously ask the patient to open and shut their eyes and their mouth, and facial expressions, have them smile. And if a patient was unable to have those facial movements, that would obviously be an abnormality. This could happen in an instance like Bell's palsy. You can see this in Lyme disease, or maybe some other autoimmune disorders that could affect that nerve. A bacterial infection, maybe that started as an ear infection, maybe even a sinus infection. Some more simple things, a stroke, a tumor. This can also affect your sensories with your ability to taste. A question I wanted to ask is, what could cause a loss of taste that isn't system related or related to the central nervous system? So I came up with, sorry, my slides moved. I came up with, you could have like affected your taste bud by if you like burned your mouth, or possibly like if you had COVID-19 or something like that. Although I think that the research has shown that because the virus can attack, that could be maybe it's attacking that part of the nerve, so that's why you can't taste as well. So moving on, we're going to go to cranial nerve number 8, the vestibulocochlear, which affects your hearing and balance. So I don't know about you guys personally, and in my nursing career, I've had patients come in like, I'm dizzy or I feel off balance. I think that's a pretty common complaint. So you would, to test this, you could use your Weber and your Rhines test, use your otoscope, check out, obviously inspect. And then I would personally, you can ask questions, do you have any ringing in your ears? Do you have any hearing loss? At this point, I think then you could assess, like, is it vertigo? Could it be something like Meniere's disease? All those like differentials you could go into. Most importantly, I think you would want to rule out an acoustic neuroma, and, maybe send them to a specialty if it was something that kept going. Cranial nerves 9 and 10 are the glossopharyngeal nerve and the vagus nerve. So we'll start with the glossopharyngeal nerve. It gives sensation to the posterior part of the tongue, and it also supplies some motor function. From what the research I could do, it was very rare. So this would be something more of like a brainstem lesion, or something. Moving on to cranial nerve number 10, the vagus nerve. This affects the sensory and motor. It senses like aortic blood pressure. It can slow your heart rate. I'm sure you guys have all heard of vasovagal, same kind of thing. It can stimulate digestive organs, and it can work on the taste. So for assessment of this, sensation of posterior 1/3 of the tongue, throat, you could check the gag reflex, stimulate the back of the pharynx with the tongue blade. Can they swallow? Things like that. If you found abnormal findings and you could not, if one of those wasn't good, you could check for, brainstem lesions, maybe do an MRI, or I don't know if they had any surgeries or any damage to that. But again, it would point you in the right direction to assess what was going on. Cranial nerve 11, which is your spinal accessory nerve, is motor supply to the sternocleidomastoid and trapezius muscles. Primarily motor, it controls your trapezius and your sternocleidomastoid. It helps control swallowing movements, muscle sense. To assess this, shoulder movements like shrugs, head rotation, push against the examiner's hands, things like that. If there's anything wrong with this, it's honestly like you would look for lateral rotation of the scapulas or shoulder drops, and most likely going to be from trauma and your trauma cases that come in. Cranial nerve 12, which is your hypoglossal nerve, motor function of the tongue. This is going to be a motor supply to the intrinsic and extrinsic muscles of the tongue. So to assess this, tongue movement, protrude the tongue, push the tongue into the cheek, abnormalities if you had some tongue deviations. If it deviated toward one side, this could be from strokes, tumors, ALS can cause this, and probably metastatic diseases to the skull base. These are my references. The takeaway from here is mainly, for me personally, as a practicing student nurse practitioner, if I can identify the cranial nerves and there's an abnormal assessment, then I'm able to identify the area that there could be something wrong. So when ordering radiological studies or trying to help diagnose the patient, it can certainly point me in the right direction. So that is all I have for you today. Thank you for watching.